No, then I've not gone to the school of nursing. But there was this woman that told me, then I was working as a receptionist in the clinic. So she came in bleeding heavily. So from the history that was given from her, she said she has been on, though it's not this one, it's not the IU, because she said she has been on Depo Provera. Was on Depo. So after like 6-7 years, this man left so severely. She was transfused. Yes, she was transfused.
Are they going to remove her? Oh.
Therefore, not this one. I just remember that it's not this one. It was therefore
For these days, we have what we give. Microchip. If they start what we give them, even when the baby start, we give them to stop.
Okay. Change stay under that. Changes in menstrual bleeding like spotting or no bleeding are common. These are normal side effects and not a sign of sickness and will not harm the woman. There is no need to lose blood every month. To lose blood every month. It is like not having monthly bleeding during pregnancy. She is not pregnant or infertile. Blood is not building up inside her. Some women are very happy to be free from monthly bleeding.
Everybody.
They're very happy.
Everybody.
I stopped menstruation 40 years. And I'm happy.
I see.
So, you see,
I don't
but I
know.
thank God I had my children very fast. By 40 years, I was not menstruating. Eh? You say what?
I do my own planning lecture.
Yes, I was in copper IE. I was on copper then.
Master, will that contribute to the early cessation of
there are
marriage?
some, like we always say, body different.
Okay.
Some people, but remember that actually cessation of menstruation can come up from 40, 45, 50. Some people, maybe 50 to 60. That is menopause. My own started very early, and I saw my menstruation very late. Very, very late.
Late and
I don't
then
finish
early.
secondary school.
Are you serious?
Yes, because even at the point I was so disturbed. I don't even know my friends. Everybody will put to toilet room. So my friends, when they are discussing, and if I come here, they will chase me away that I'm still a small girl. That I'm not seeing my feelings. So I started putting toilet room. Whether their blood or not, to tell you that me too. I remember it was after my wife. The thing came out. After my wife, so it came out and it stopped early. That's, God has a way of doing things. I got married immediately after my secondary, my school of nursing. I got married and I started making children immediately. As if God knows. As I did small, stop breastfeeding and they enter another belly. So till I finish the 4 of them, 5 of them, when I now finished, menstruation. But I like it. I like it. And that my period was so, even when I was menstruating, I can move the whole day without putting pad. Yes. It draws. It may just stain my pants. So therefore, hygienic purpose, I wear pads. If not, nothing. Say menstruation don't come and they run. I will use it and do everything and go house and remove that pipe. So continue.
Different body.
Still under women, the woman might travel inside the woman's body to her heart or her brain.
I think you've had that one. You say the waka inside.
Fact, there is no passage from the uterus to the other organs of the body.
From one of these that I have with you,
That they were
recently,
that what
they were looking for me saying,
they can miss, they didn't have. It can be missed. Either that missing, remember you were here from the beginning. You were here from the beginning when I mentioned something. I said sometimes if not well placed
Inserted.
or during menstruation, I mentioned it.
Like heavy flow.
It can expire.
Heavy flow, people with
Heavy
heavy
flow can
flow.
push it out. They wouldn't know. And that's why when you are counseling them, always remember to tell them during menstruation they should always inspect their parts before they discard.
Okay.
Because if you don't and you have thrown it away, you will say the
It's,
missing one.
say it's not working.
And
Even
as
say
you
it's
get
not
pregnant, they
working.
start to carry instruments, they search everywhere. But some actually dislodge. They are inside there, but they are no more in their position. So most of the time, scan can pick them out. Even our implants can, yes, that one can move, but not to go to your brain.
No, sorry. I think that was April. A client came to my facility with this missing implant. The doctor tried and he
They
could
should
not
have
find
gone
it.
for, they should have gone for scan.
Okay.
That
So
one
you
took
sent
and
her
pull
to go
out.
for scan.
And no, scan say nothing is there.
No, I have not seen that again.
Scan can say nothing is there. Do you know why? Now, we normally do incision, small incision. Is it not? And
Yeah.
put it. And we tell them, don't do heavy, don't lift. Is it not what you
Yes.
do?
Yes.
Don't do all those things. Don't go and cut your firewood, all those things. Some of them, they cannot help. The only way for them to eat is by lifting. And sometimes that thing can fall out before healing. They wouldn't know. Are you getting me? They are saying the same thing. So try, that is why counseling is very, very important.
Do you know my own experience? I had IUFD at 7 months at a general hospital in Andoni. So I decided to go for implants, but that happened after my 2 babies. I didn't know that the SNO that inserted it was implant, not classic, no NST. You know, that one has a lot of skill. I didn't know that she did not succeed in fixing it. So I went home.
And she didn't tell
You
you.
didn't tell
She
you.
didn't tell me.
Similar thing happened to me too.
She didn't tell me. So I was happily going home with something that I have carried something. So, but much later, because my tummy was too bloated, after scan, so some persons now advised that I should take this with that stuff. I started bleeding heavily. So all my mind is that it was the implant. Not knowing that the implant was not even there. I took micro-gynon, it did not stop. The bleeding was so heavy that if I sit on a custard, I couldn't go to toilet every week. It will fool the custard rubber. I became so worried, I had to go to UPTH for removal. So they searched. I even met the consultant. They all sat, they pressed my hand, they couldn't say anything. They said, okay, go for scan. I went for scan. Scan did not detect anything. They said, go for x-ray. I went for x-ray. They even opened this my arm to search. Maybe it's really hiding anywhere. They didn't see anything. They said in their presence, because that person was trained in UPTL. I should call the sister. She said, it's there now. I put it in there.
Oh my God,
Wow.
happened to me.
No. So
My
I
own
went
was
from
removed.
I took in when I stopped taking that wood. Meaning nothing was actually there. Yes, it was the wood that caused it.
My own was ordinary removal. After 10 years, I went for removal. I didn't know that the nurse doesn't know what to do. And that is why when you are counseling, you have to show them. When you remove this thing, you show them. I was not shown, and that time I don't have knowledge. So I thought she removed it. So after 13 years, I started manifesting problem. Started having discharge. Everyone pouring like water. So she had problem. I went for pap smell, went for different tests, high vagina swab, nothing. When they give me antibiotic, as I'm on that antibiotic, it will relax. As soon as I'm dropping it, it start again. At the point, I became frustrated. I don't know what to do. So the doctor was saying that, okay, they will go and do scan, they will do this, they will take me to theater. it was that week they were contemplating to take me to theater. I heard a clear voice say, hormonal IUD is still inside there. And the IUD is still inside. I woke up, I said, how? How can IUD? The lady removed it. I slept again. The following day I heard her say, IUD is inside there. I ran to the toilet, washed my hands. Apparently because I do what they say we should be doing. Do not preach. So like I just washed my hands, pushed my hand deep, and I felt it. I felt it. I wanted to pull, but it was like my womb was coming with it, so I left it. It was 13 years. I rushed to the cottage hospital. I just dressed up. I just told my husband, Daddy, see the problem of that thing. IUD is still inside. He said, how? They removed it. He said, I said, they don't remove it. I ran straight to you. Ogobe is very close to my house. When the sister heard that, the sister, I said, sister, try first. Try first. If you don't work, then I'll go to share clinic. Then they put me in the theater. Like the sister just jumped and came out to one house. Not share though, no, not share. Not share. But now this, our nurses that come from state, these locals.
But what is wrong in telling the person that you couldn't remove it? And look for somebody else.
Moved everywhere. They could not see my head. Almost
don't
all
mean
the nurses cried just to get my service. Because
You don't
they had to. They went and changed bed. Did like this and I was listening. So at the end of the day, whether they succeeded or they did not succeed, they just told me they succeeded.
But like one of the clients we had here last week, we battle my students in fine service, tire service program. I now came, me with the expert one hand, I don't pick service. I pick. I said, Doctor, Olaka, come and try. Olaka struggle with those service. Olaka said, wait, now I know the problem. I said, what is it? He said, this woman, he said, this postcodes we are using is small. He now looked for big one as a job food. Thinking. So apparently that may have been a reason. And they could not be different
sizes.
So,
They
and that Costco can pay inside there. So they hit your waist. So it's unfortunate, it's a bad experience. Honestly, that one, I started thinking whether I would soon die. Because nothing. And heavy antibiotic they were giving me. But I thank God I'm well. So let's continue.
They are still on that part. A woman can't get pregnant after using a hormonal IUD. Fact, there is no delay in the son to fertility after the hormonal IUD is removed. Studies have shown that most women who discontinue the hormonal IUD become pregnant as rapidly as those who have never used contraception. Studies find no increased risk of infertility among women who have used hormonal IUD, including young women and women with no children.
Is that it?
Yes, for her. So I will continue.
Okay, continue. I'm lost. I will pick you.
So we are still on the
32.
Rumors or misconception and facts and realities. Okay. So rumors that a woman who was using a hormonal IUD became pregnant. The hormonal IUD became embedded in the baby's forehead.
Yes.
Facts and reality. The baby is very well protected by the sac filled with amniotic fluid inside the mother's womb. If a woman gets pregnant with a hormonal IUD in place, the health provider will remove the hormonal IUD immediately due to the risk of
And it
infection.
will affect their food there. It will affect their food.
If for some reason the hormonal IUD is left in place during a pregnancy, it is usually expelled with the placenta or with the baby at birth. Rumors and misinformation that hormonal IUD roots in the uterus after prolonged use. Facts. Once inserted and if there are no problems, the hormonal IUD can remain in place for 3 to 7 years, depending on the type of hormonal IUD. The hormonal IUD is made up of materials that cannot deteriorate or lose. It simply loses its effectiveness as a contraceptive after 3 to 7 years, depending on type. Note, the information and misconceptions below apply more directly to health workers. Now, under rumors or
I hope you have
misinformation.
seen that 6 weeks. I say healthcare workers.
Yes. So, still under rumors and misinformation, they say that a hormonal IUD can be inserted until 6 weeks.
Can't be.
Okay, sorry, can't be inserted until 6 weeks postpartum. Facts. The hormonal IUD can be inserted immediately after the delivery of the placenta or up to 48 hours following delivery or immediately following removal of the placenta during a cesarean section by a trainer provider. Expulsion rates for postpartum insertion vary greatly depending on the timing of insertion, type of hormonal IUD, and the provider's skill. Current information indicates that expulsion rates may be higher during the period from 10 minutes to 48 hours after delivery as compared with the first 10 minutes period. To minimize the risk of expulsion, only properly trained providers should insert hormonal IUDs postpartum. After the 48 hours postpartum period, hormonal IUD may be safely inserted at 4 or more weeks postpartum. It has been shown that hormonal IUDs do not affect breast milk and can be safely used by breastfeeding women postpartum. Rumors that the hormonal IUD causes ectopic pregnancy. Facts. No. On the contrary, hormonal IUDs are protective against ectopic pregnancy.
We've heard it before now.
Yes. Ectopic pregnancies are rare among IUD users. The rate of ectopic pregnancy among women with hormonal IUDs is 12 per 1,000 women per year.
10,000.
10,000 women per year. Sorry. The rate of ectopic pregnancy among women in the United States using no contraceptive method is 65 per 10,000 women per year. However, in the rare occasion that pregnancy occurs with the hormonal IUD in place, up to half of pregnancies are likely to be ectopic. Hence, it is important to rule out ectopic pregnancy if pregnancy occurs with hormonal IUD in place, as this is a life-threatening condition. Another rumor. Women who have never given birth cannot use an hormonal IUD. The fact, World Health Organization carefully reviewed all evidence before listing non-reparity as category 2. Generally use some follow-up may be needed because a woman who has not had children has a smaller uterus than a woman who has been pregnant. The hormonal IUD is slightly more likely to come out. Next question.
Okay.
Which should be fast, my laptop.
Okay, so another one is rumors on his concession. He said women infected with HIV cannot use an hormonal IUD. Fact, hormonal IUDs use hormonal IUD use appears to be safe for HIV infected women with mild or no clinical disease, whether or not they are on antiretroviral therapy. However, women who have HIV with advanced or severe clinical disease should not have an hormonal IUD inserted. If a woman develops advanced or severe clinical disease while using an hormonal IUD, she can keep using the hormonal IUD but should be closely monitored for pelvic inflammatory diseases. Hormonal IUDs do not increase the risk of becoming infected with HIV or transmitting HIV to a partner. Women who have HIV or at risk for HIV should correctly and consistently use condoms along with the hormonal IUDs to help prevent transmission of HIV and other sexually transmitted infections. Rumors or misconceptions say hormonal IUDs increases the risk of pelvic inflammatory disease and must be removed when it occurs. Fact, by itself, the hormonal IUDs does not cause pelvic inflammatory diseases. Gonorrhea and chlamydia are the primary direct cause of PIDs. Hormonal IUD insertion when a woman has gonorrhea or chlamydia may lead to PID, but this is very rare. When it does occur, it is most likely in the first 20 days after hormonal IUD insertion. When appropriate questions to screen for STI risk are used and hormonal IUD insertion is done with proper infection prevention procedures, including the no-touch insertion technique, there is little risk of infection.
Can you reach to the family planning consultation? It was one Marina. Because I didn't even come with that one, we go through that one. Yeah, so because they need to see it.
Okay, it has been estimated that in a group of clients where STIs are common and screening questions identify half of the STI cases, there might be one case of PID in every 666 hormonal IUD insertions. That is, or less than 2 per 1,000 persons. There is no need for antibiotics to be routinely given before hormonal IUD insertion. In the case the woman develops PID with hormonal IUD in place, treat the PID. There is no need to remove the
Have I said that
hormonal.
in today?
Yes.
You will see all those cases. Don't say, hey, infection don't come. Don't remove. Treat the woman.
There is no need to remove the hormonal IUD if she wants to continue using it. If she wants to get it removed, take it out after starting antibiotics treatment and provide her with other contraceptive options.
Right.
Yeah.
So now, the next thing we would have done would have been role play. But we will move to timing of insertion of IUD. When we finish the insertion, please remind me, we'll come back to role play. Let's take that role play. Is that clear? So Then it's after the role play, I will now do video for hormonal IUD. Apparently, Thursday or Friday, I still showing the 200 hormonal IUD. Is that clear? So now go to yes, timing of HIUD. 44. Okay, page 44. So this lady, I will tell her people that she didn't learn it. Why is she moving everywhere? We are not entering timing. She will not learn it.
Timing of hormonal IUD insertion. Having menstrual cycles or switching from a non-hormonal method. If menstrual bleeding started in the last 7 days, can insert hormonal IUD now. No backup needed. 2. If menstrual bleeding started more than 7 days ago, can insert.
Can you remember what I said about dislodging? That the IUD can dislodge. Did you remember?
Yes. Yes.
So use that at the back of your mind. Remember I said when the person is under period, menstruation, we don't also encourage it. Did I say something like that?
Yes.
So use that at the back of your mind. Repeat if menstrual bleeding.
If menstrual bleeding started more than 7 days ago, can insert.
More than.
Less than.
Meaning that it's coming down, it has settled. Is that clear? Excellent.
Can insert IUD now. If reasonably certain she's not pregnant, no need to wait for next menstrual period. Need a backup method for the first 7 days after insertion.
Want me to explain? What they are saying there is that if 7 days after menstruation, apparently the woman didn't meet with her partner, you are very convinced she's not pregnant, you can insert. Or if you are not sure, you should do pregnancy test. That is normally what we do. And again, if no need, that is, ideally, or if we don't want to wait for PT, we can say go and come when you are next pregnant. There is no good. Family planning, we don't give them nest. There is no nest in our mouth. Because when you tell them nest, that nest, they're not coming back. Is that clear?
I have one experience.
So no need to tell them go and come. That is why they say if reasonably certain you are sure she's not pregnant, don't need to wait for next menstrual period. Need a backup method for first 7 days. Remember, I also said when we started, I said for every hormonal, you must allow them for 7 days after insertion. I said give a backup, no sex after giving a hormonal, whether pills, injection, implants, no sex for 7 days. But if the person is not sure they may have sex, give them backup. Did I say something like that? Yes. Okay, continue.
Switching from a hormonal method. If she has been using methods consistently and correctly or otherwise, certainly not pregnant. If menstrual bleeding started in the last 7 days, can insert hormonal IUD. No backup method needed. If menstrual bleeding started more than 7 days ago, can insert hormonal IUD now. Need a backup method for the first 7 days after insertion. If switching from an injectable, can have the hormonal IUD insertion when the repeat injection will have been given. No backup method.
Do you understand that? If the person is taking injection, person has been on injection, person now said, I don't want to do injection again, I want to take HIUD. He said that day where the person comes that is due for her injection, he said that day, no backup, the person is not pregnant because the hormone is already in her system.
No monthly bleeding, not related to the childbirth or breastfeeding, can be inserted anytime if reasonably certain that she is not pregnant. Use a backup method for the first 7 days after insertion. HIV can be inserted in the first 2 days after you give birth, whether or not you are breastfeeding. Can insert within 48 hours after birth if no postpartum infection. Special training needed. Can be inserted during a cesarean delivery after removal of placenta and before closure of the uterus. More than 3 days or less than 4 weeks after giving birth. Between 48 hours and 4 weeks after birth, delay insertion. Offer conditions or other methods if it is not fully breastfeeding. Timing of HIV insertion. If not inserted within 2 days after birth, HIV can be inserted anytime after 4 weeks for fully or nearly fully breastfeeding period. If monthly bleeding has not returned and in less than 6 months postpartum, can insert with IUD anytime. No backup method needed. If monthly bleeding has not returned and more than 6 months postpartum, can insert IUD anytime if reasonably certain that woman is not pregnant. Use backup method for first 7 days after insertion. If monthly bleeding has returned, can have HIV inserted as advised for women having menstrual sex as discussed. If not inserted within 2 days, HIV can be inserted anytime after 4 weeks postpartum. For women who are partially breastfeeding or not breastfeeding, if monthly bleeding has not returned, insert anytime if it can be determined that she is not pregnant. Use backup within 7 days after insertion. We're just repeating it.
Thank God you have noticed that we are repeating it. I will not repeating it. So let's move, let's shift away from there. Addressing rumors, we have addressed it. We took time to address it. So let's push on. Let's go explaining the IUD insertion procedure. Abi?
Together with one, take the current history and conduct a full physical examination.
Very, very important. We should not do, because even in your taking a physical examination of the child, you can discover that the breast may be tender. Something is already there. Are we following? Yes. So if that is the case, what will you do? If you are the top pregnancy, if you are palpating and you get to the breast and you discover a lump, something hard, what will you do? You stop and repair the threat. Exactly. But if you didn't do, you will not know. Okay, continue.
Perform abdominal examination. Inspect and palpate the abdomen.
You must, so when we start it, you must do it. You palpate the abdomen, press. You will tell us what you are expecting to see there.
Check for suprapubic tenderness.
Are you hearing it? Write somewhere that kind point. You put it. This is the real thing we came for. All the other one are story. This is so what, because when you want to, when we start the this hands on, you begin to tell us, I'm doing palpation, I'm palpating, I'm checking the suprapubic, if there is any suprapubic tenderness. Just pick points. Okay?
Number 3. Perform vaginal examination.
Yes.
Check for ulcers,
Yes.
lesions or discharge.
Yeah. When you get to the vaginal side, when you finish your abdominal palpation, you go to the cervix, the vaginal examination. You check whether the place is soft, or you check whether there is swollen, whether there is an ulcer, where is wound, discharge, anything you can describe there, you check. Exactly. So what next?
The next thing you do is that perform a
By manual person, the pelvic exam. Do you know how to perform it? By manual. When they say something is by manual, what do they mean? two hands. One hand is inside the vagina. This other hand is at the suprapubic. You understand? You are pushing it down, checking, using your hand, using your brain. Anybody has done midwifery? You know it's how we do it. Abi? So continue.
To check for cervical
Adlizard.
and uterine abnormalities. Perineal insertion.
Like one woman, one of our clients on Friday, when we were examining her, by the time we put posters, we now saw growth coming out from the cervix. So we doctor big sample. The doctor said at that point,
Who is Madam Ella? Eunice, not Ella. You are the one. Please.
from her hospital, yeah.
Must not on.
So at that point, in case you open, it's part of the things you expect from the service, whether very good, whether there's any growth. Except you read the listing and
Clean the cervix and vagina with aseptic.
so when you open it at that point, when you are doing by manual examination, that time you have not put colposcopy. I will follow you. You first of all clean the vagina. How do we clean? The two majora first, the right and the left. The majora we clean 5 times.
The measure.
Majora 1,
Minor.
left and right.
Okay. Then English.
And the same, yes.
Okay.
1. When you do it, I watch you have embarrassed somebody there. We teach another thing, you go back and you start practicing another thing. You use your sponge holder. You take your solution. Because we are doing combined and integrated, we are not using this on a color. What is that color? The disinfectant.
Savlon.
Not Savlon.
Evitent.
Not Evitent. There's one common one we use that is like a dye.
Covidon.
Providon. Because we are doing 2 procedures in one. We are not using Providon. So what we are using is normal saline.
Okay.
We are using normal saline. So when you clean, you take the clean 1, clean 2.
I used to read it. I used to Marcus, can you read this? Marcus,
Is she working with you?
What
Are you the one reading? Are you the one reading? Go fast. Let's wait. The class is divided. So let me be explaining. So what I'm trying to say is when you now clean 1, 2, minora, left, right, and you that's one. Midwives. Center is called what? I know we'll talk. We're gonna go do research. Continue. How will you say you don't know how to clean? You've cleaned left and right. The center is what?
That's the vulva. The vulva.
So when you call vulva, when a market woman call her vulva, you two call vulva.
So market woman no go call vulva.
Now vulva they call her. When they call her, vulva is the general name now.
Not common.
Center is called what? Oh, no. Let's continue. Okay, continue.
Okay. She stopped.
I think she has read it.
She has read
So you start and check for cervical. Okay, she has read that one. Sir.
It was the next one. Clean the cervix and vagina with antiseptic. Slowly insert the tinaculum through the speculum.
That time, now, what they are telling you, you have inserted the speculum. You you have inserted the couscous. You have done what they say through have you seen the vernacular before? Have you seen yes or no?
Yes.
It's
She say yes. Just talk your own. And you have not seen it. It looks like two sharp edge. It's like this, sharp. It's an instrument. What they use through the open, using the couscous, they pass through to grab the posterior of the cervix. And what they do that is to stabilize the cervix so that when you want to use a uterine sound, it will be balanced. It's okay, continue. You always frowning when they ask you, have you seen this before? Don't frown, just say, I have not. Apparently, that's why you are here, exactly.
Okay. Slowly insert the tenaculum through the speculum and close the tenaculum just enough to gently hold the cervix and uterus steady.
Wasn't that what I said?
Next, gently insert a rod as uterine sound into the uterus to measure the depth of the uterus.
You may not see her. I need that thing. I want to show them.
So that the hormonal IUD can be correctly placed. Slowly and gently pass the inserter through the cervix. Releases the hormonal IUD at the fundus, at the top of the uterus, and removes the inserter. Cut the strings, leaving about 20 centimeters hanging out of the cervix.
Continue. See, you are moving too much. I will report to that you are not part of this class. All the timing of hormonal IUD, you were not here. The essence is not because you are here. I told you your colleagues, they were so active, you never looked for them. You are always going out. Even when I was looking for you to bring this.
I was the one that went to bring the
No, maybe they saw her side. She was not here when I was looking. I have to send the mail. And that is a long story now. Don't you people know when I started looking for her? Please settle down. That's why even if this is your facility, you know everywhere. Calm down so that you learn. If not, you'll be moving around. You'll miss so many things. We have gone far. You have missed a lot.
Now, I want to ask a question. This using the tenaculum to steady the cervix. In this particular one, we are not giving any angle to plan.
You will see it. But I have told you in advance. Most things I tell you in advance, is so that when you reach there, it will not surprise you again. You will see it. But continue.
But I'm forgetting what you mentioned.
Okay, I said the posterior aspect of the cervix. You know cervix, now see there like this. Posterior is up.
Posterior is down.
Oh,
Up is
anterior. Where be up? Anterior. Yes. You see, the anterior, that is the upper part.
Yes.
That vernacular we just use and grab the head of the cervix. At 12 o'clock, excellent. At 12 o'clock. Is that clear? Who is ready?
Post-insertion instruction. Expect cramping or spotting for a few days. Suggest ibuprofen 400.
These are things you will not tell your client. They are telling you what you should do. Postpartum insertion, post-insertion instructions. They are telling you what you should do. That you should expect this, expect cramping and spotting. So they are telling you can now give ibuprofen. It's okay. Let us understand what the book is saying, so that when you are reading it, it's making meaning. Okay, continue.
400 to 800 milligrams. Paracetamol 500 to 1 gram.
Meaning that you can also do paracetamol.
Or other pain reliever agents. Secondly, you have to be aware of the possibility of IUD expulsion.
Exactly.
If expulsion is noticed, start using a backup method and come back as soon as possible.
You are telling how. I hope you are understanding the story. Post insertion instruction is you are not passing this message to the client. But like paracetamol or ibuprofen, you cannot prescribe because what the thing is telling you is that you should be expecting this, and you to tell her that you maybe after some days you will expect this. In case it happen, take ibuprofen. Is it clear? If in case it happen, take ibuprofen, and or if you don't have ibuprofen, you can take paracetamol. Is it making sense? Continue. And you are also telling her, you are telling the client, say beware of possible of exposure. You are telling her. So continue.
If possible, come for a follow-up visit at 3 to 6 weeks to check for expulsion or infection. Return immediately if there are any warning signs suggestive of complications. Remember when to come back for IUD removal. If possible, give a client card with details of the type of IUD, the date of insertion, and the date of removal of the place. Explain the removal procedure to clients. The provider will insert a speculum to see the cervix and the IUD strings. You clean the cervix and vagina with an antiseptic. You ask the woman to take slow, deep breaths and to tell the provider if she feels pain during the procedure.
This information is for you.
Using forceps, pull the IUD string slowly and gently until the IUD is
That is
completely
the
out of
remover.
uterus.
That is the remover. It's a simple procedure. You use the ocoscos, you put as you insert, you clean the vagina, you will see the thread. You clean the vagina, the cervix. After that, you use your sponge holder, grab the thread, and gently, when you are doing, you pull down. Don't drag like this. You just come down, come down, come down. Come out. Okay?
Complications.
Okay, you can also tell the woman, some people sometimes will say cough. You say,
Say your own advocate.
exactly. It's okay. Continue.
Complications of hormonal IUD. Problem, expulsion, risks.
This thing they there, this question they there. Continue.
Generally low, about 10 per 100 liters over 2 years. Linked to provider skill, age and clarity of woman, timing of insertion, were reduced through by provider training, supportive supervision. Still under problem, pelvic inflammatory disease. Risk estimated at approximately 1 in 666, depending on sexually transmitted infection prevalence. Linked to presence of cervical infections or chlamydia to gonorrhea at time of insertion. Reduced through by screening women for risk of STIs prior to insertion. Problem, perforation. Risk, very low, 1 in 1,000 insertions. Linked to provider skills, correct insertion technique, careful pelvic examination to determine size and position of uterus, breastfeeding status and time since delivery. Then reduced through provider training, supportive supervision. Signs of possible hormonal IUD complications. Advice to return immediately in case of 1. Signs and symptoms. Bleeding and severe abdominal cramping within a few days post-insertion. Unexplained vaginal bleeding, for example, after a pattern of bleeding has been established, or pain in every cycle. Fever, chills, unusual to foul-smelling vaginal discharge, lower abdominal pain. then missing hormonal
If
IUD.
you take it like this, it doesn't work that way. When you take one signs and symptoms, you take the possible cause. Please repeat.
Signs and symptoms: bleeding and severe abdominal cramping with a few days post insertion, possible for perforation. Signs and symptoms: unexplained vaginal bleeding.
Side effects, if take her concern seriously. Tailor counseling to the client's needs, focus on key information, and use words the client understand. Check the client's understanding, respect and support the client's decision. Invite client to come back anytime for any reason. And managing hormonal H hormonal IUD side effects or complication, changes in bleeding patterns. The problem and then action or management. Problem now, irregular bleeding or spotting. Action, reassure client that this is common and not harmful. Usually diminishes after few months. No monthly bleeding. Reassure her that many women eventually stop having monthly bleeding when using hormonal IUD, and this is not harmful. Blood is not building up inside her. There is no need to lose blood every month. Rather, it protects women by preventing anemia. Heavy or prolonged bleeding. Reassure client that this is common and not harmful. Usually diminishes after months. Provide iron tablet and encourage the client to eat food rich in iron. Okay.
Managing hormonal IUD side effects of application. Cramping and mild pain. Counseling and reassurance are key. Problems: cramping and mild pain. Action/management. She can expect cramping and pain in first 1 to 2 days after insertion. Suggest ibuprofen 400 to 800 mg, paracetamol 500 to 1000 mg, or other pain reliever, not aspirin if she also has baby delivery. If cramping continues, evaluate for other partial expulsion or perforation or other causes. Treat or refer. If cramping is severe, there is no underlying condition, discuss removing the hormonal IUD and switching to another method. Severe pain in lower abdomen, rare. Rule out pelvic inflammatory disease, ectopic pregnancy, ovarian cyst, perforation. If ectopic pregnancy is suspected, refer immediately. If PID is suspected, treat with appropriate antibiotics immediately, e.g. ciprofloxacin 500 mg daily for 5 days, doxycycline 100 mg tab orally twice daily for 7 days, metronidazole 400 mg tab orally twice daily for 14 days for gonorrhea, chlamydia, and anaerobic bacterial infection. There is no need to remove the hormonal IUD. If ovarian cyst or enlarged ovarian follicles suspected, reassure clients they usually disappear on their own. No need to treat unless they grow abnormally large, twist, or burst. Can continue to use hormonal IUD. Follow up in 6 weeks to ensure problem resolving.
Managing HIV side effects of education, suspected perforation. If perforation is suspected at the time of insertion, stop procedure immediately. Remove all instruments and HIV if inserted. Observe vital signs every 5 to 10 minutes for an hour. Check for signs of bleeding or shock. If rapid pulse, falling blood pressure or reduced pain, refer immediately. If stable, observe several more hours. HIUD come out. Perform pelvic examination, gently probe for spleen in cervical canal. If do not locate spleen, consider X-ray if pregnancy can be ruled out, or ultrasound or refer. Provide a backup method in meantime in case HIUD came out and the woman did not notice. Insert another HIUD if the expulsion is confirmed and she is not pregnant and she wants to use the HIUD.
Managing HIUD side effects or complications, suspected pregnancy. When pregnancy is suspected based on absence of bleeding and or symptoms of pregnancy, absence of pregnancy including ectopic pregnancy by pregnancy test or other means, which is ultrasound. Inform client of your findings and explain that HIUD in the uterus during pregnancy, including the risk of preterm delivery or miscarriage, possibly septic, during the first or second trimester. Explain if she is planning to continue the pregnancy. It is best to remove the HIUD, although the removal procedure itself involves a small risk of miscarriage. If client consents, refer to an obstetrician to remove the device by gently pulling the strings. Refer for antenatal care. Counsel client to return to clinic if abdominal pain and bleeding spotting occurs. Managing HIUD side effects or complications, suspected pregnancy. If the string is not visible, refer for ultrasound, if possible, to determine whether the HIUD is still in the uterus. If it is, or if ultrasound is not possible, our pregnancy should be closely monitored. Follow cancer to seek care without any delay if she experiences symptoms of miscarriage/infection.
In summary, HIUDs are safe, private, highly effective, convenient, reversible, long-lasting, cost-effective, easy to use, and appropriate for the majority of women. It offers important health benefits, including but not limited to protection from endometriosis.
So where did this come?
Summary.
So we are done. So we will now go to this one is passing the uterine sound. We will do that one with the video. Because we don't have that complete set yet. Is that clear? But the one I will only open the slide and we don't have expired yet. So let me see what we are going to do. Passing back, go to passing the uterine sound. Which page?
55.
But let's continue.
Purpose of passing a different sound. One, to check for any obstructions in the cervical canal.
Because sometimes when you are passing, you may not pass, especially if there is any obstruction. Continue.
To measure the distance from the external cervical os to the uterine fundus, so that the gauge on the insertion tube can be set at the same distance. To ensure safe and
That one, I
correct.
wanted to say that is the number one help to prevent uterine perforation. I will open it so that you see it.
I've had this she wanted this thing, so I wanted to sound the uterus. There was this person, I don't know whether it's obstruction, I could not, when I don't put it, the thing is not going to
There are times
it will happen. She now said I should put implant for her.
Who said
The woman was the one that naturally said that will now use implant.
actually sometimes even when you do that, like I know there was a client almost uterine exam. Even sometimes if You just need to put small pressure. Small pressure. No, that make a go scatter the things there, but little pressure. Immediately you pass it, you just see, ooh, it will be going freely. At that point, you are uterus. But and again, when you measure, because this is very important, when you measure, I don't know whether it's there, but let me just say it so that in case it's not there, you know it. And the measurement is like less than 5 cm. You cannot insert. That is one of the reasons why we get what? Different sand. I said if you measure the sand, the depth of the uterus, and you see 4 cm, 3 cm, 5 cm, I said don't insert. Why do we do that? Why did I say don't insert? Atama for her. When you learn, application. So they talk here that expulsion is one of the common reasons. A woman with a very short uterus, 4 cm, or even you piece itself, small pen, it will go up. Is that clear? Okay, continue.
Sorry. There was another case that was.
I'm sorry, and if it's above 8, if it's above 8, like 9 cm, you don't also insert. You leave it for the doctors.
As that was there, I was going to when we were doing our post-abortion training, the lady that I used for my practical, we did the surgical part. I did surgical part for her. So we said to insert IUD. By the time we started the uterus, it was about 9.
I'm telling you not to do.
So I said,
I hope you've had seen it practical. Because why did we say don't do? Can dislodge. Can dislodge. Commonest this thing can dislodge. Too high, above 8, don't.
but why is that so high? Is it that
God, more so. Nobody can. Me, I can't explain. Just like what I told you when we did one trying to inspect the service. We got to know we decided to change those schools to a very big one. That was when the service was